Good morning, everyone. The topic for our lecture today is management of traumatic injuries, and we will be covering this in two parts, part one and part two. So, this lecture is part one lecture where we'll be covering the first half of the management of traumatic dental injuries. Traumatic injuries to teeth can mainly occur in any age. So, usually in young children, it is the time when they're learning to walk. So, that is when they might fall off from a chair or fall off while they're trying to walk, resulting in dental injury. Child abuse is another cause of dental injury. Mostly sports accidents and fights also result in knocking out of a tooth. And an unfortunate incident or unfortunate happening that can happen to anybody at any age is that of an automobile accident. So, to sum up, the common causes of traumatic injuries are sports accidents, automobile accidents, fights and assaults, domestic violence, inappropriate use of teeth, and biting hard items. The Ellis and Davy classification of traumatic injuries is the most commonly asked classification. There are other classification as well, like the Andrea's modified classification of traumatic injuries to teeth, or the Hitsey and Morrell classification of subgingival fractures, and Anderson's modified classification of soft tissue and bone. But at an undergraduate level, it is enough if you know the Ellis and Davy classification. Firstly, studying about enamel infarction. So, by definition, it is an incomplete fracture or crack of the enamel without the loss of tooth structure. On visual examination using dyes, along with magnification, can always help in visualizing an infarction better. And we can also use trans illumination using a focused light. So what happens is when the light passes through the tooth and it encounters a fracture line, it usually bends and does not pass through the fracture line. So the opposite tooth becomes dark and you can visualize the line. These tooth are usually not tended to percussion and you don't see any radiographic abnormalities. So treatment of enamel infarctions in cases of marked enamel infarctions, etching and sealing with resin can be done to prevent discoloration of the infarction line. Otherwise, as such, no treatment is necessary. A crack line or a chip of the enamel is basically the key clinical feature of fractures. Next up is the enamel fracture. So, a complete fracture of the enamel is known as the enamel fracture. Clinical features are that you usually encounter loss of enamel, and there is no exposure of exposed dentin. Neither is there any tenderness or percussion, and normal mobility and pulp sensibility test is usually recommended. In radiographic findings, you will be able to you will encounter visible enamel loss, and for radiographic evaluation, three angulations are required. That is periapical, occlusal, and eccentric exposures, just to rule out luxation injuries or root fractures. You may also take a radiograph of the lip or cheek to search for tooth fragments of foreign material which might have gotten embedded in it during trauma. Coming on to treatment, the chipped enamel might make the tooth rough and it may become an aesthetic problem to the patient. So, the treatment involves smoothing the rough margins to prevent laceration of soft tissue. And if the enamel fracture is too extensive, then we can always recontour the roughened margins followed by composite restoration. And in the third case scenario, if the fractured fragment is available, it can always be repositioned and bonded to the tooth. Over time, periodic assessment of such teeth is usually recommended, and a clinical and radiographic evaluation can be done at 6 to 8 weeks and 1 year. Enamel dentin fracture without pulp exposure is a fracture that is confined to enamel and dentin without the loss of tooth structure but not exposing the pulp. And the objective in treating such a tooth is firstly elimination of discomfort, secondly preservation of the vital pulp, and thirdly the restoration of fractured crown. So, in clinical features, the tooth is usually not tender on percussion, and if at all tenderness is observed, then the tooth must be evaluated for luxation or root fracture injury. There is normal mobility, and pulp sensitivity test is usually positive. On radiographic findings, we'll always, of course, find the enamel dentin loss will be visible in radiographs. Uh, the three radiographs recommended are periapical, occlusal, and eccentric exposure. For the same reason, like before, to rule out tooth displacement or possible presence of root fracture. And in this case, also, we suggest that you take a radiograph of lip or cheek lacerations just to search for tooth fragments or foreign materials. The treatment of such a case, usually if it is an uncomplicated fracture and if the remaining dentinal thickness is 2 mm, then it is sufficient enough to shield the pulp and we can expect a good prognosis. Pain on percussion, if at all it does occur, is usually transient as long as the vascular supply to the pulp remains intact. Then we can, composite restorations in these cases are preferred, and in certain cases the fracture segments can be approximated and bonded back with the help of dentin bonding agents and composite restorations. You can also go for indirect veneering procedures. So clinical and radiographic control at 6 to 8 weeks and 1 year is recommended. The tooth should be periodically tested with electric pulp tester or endo eyes. So if the pulp continues to respond normally, that means we can assume that the pulp has recovered. If progressively more and more current is required to elicit a vitality response, so we can assume that the pulp is undergoing necrosis, and that might necessitate an endodontic treatment in the coming time. Enamel dentin fracture with pulp exposure is a fracture involving the enamel and dentin with loss of tooth structure and exposure of the pulp. In clinical features, you see normal mobility, tooth is not tender on percussion, and if at all tenderness is observed, then of course we have to rule out root fracture and luxation injury. Radiographic findings, we will find loss of tooth structure, and the treatment of such cases, primary aim of a fractured crown presenting with pulpal exposure is to maintain the pulp vitality. That is most important. So management is to be based on the status of the pulp tissue and the degree of root closure. You can either, depending on these two things, you can either go for direct pulp capping or pulpotomy. The one thing to remember, which is clinically important, is that the extent of fracture and the stage of root development are the two critical factors that will determine the treatment plan. Crown root fracture without pulpal involvement are fractures involving enamel, dentin, and cementum with loss of tooth structure but not exposing the pulp. So this particular kind of dental injury is characterized by an oblique fracture line that begins a few millimeters incisal to the marginal gingiva and extends beyond the gingival crevice. Clinically, the displacement of coronal fracture segment is minimal as the fracture segments are held together by the PDL. So tooth is tender on percussion in these cases and coronal fragment is usually mobile. Radiographic findings, you will see a apical extension of fracture is usually not visible, and the radiographs recommended are periapical, occlusal, and eccentric exposures for the same reason, to detect, to rule out luxation injuries and root fractures. Treatment for this are mainly three modalities for the treatment of crown root fractures without pulpal involvement. That is localization of fracture line that can be done using a CBCT, emergency treatment that will involve temporary stabilization of the loose segment, and lastly definitive treatment. So it includes removal or reattachment of the fractured segment. In cases of subgingival extension, the treatment principle is to convert a subgingival fracture into supragingival fracture with the help of gingivectomy or sometimes ostectomy. Crown root fractures with pulp involvement are fractures involving enamel, dentin, cementum and exposing the pulp. So the fracture line in these cases is usually single, but multiple fractures can be seen occasionally. The tooth is tender on percussion, and of course, because there is a crown root fracture, the coronal fragment is mobile. Radiographically, apical extension will not be visible, usually is not visible, and the radiographs recommended are periapical and occlusal. The treatment of such cases depends on the pulpal diagnosis. So if the pulpal diagnosis is irreversible pulpitis, then endodontic therapy is recommended. So in cases where there is crown root fracture with pulpal exposure and immature roots, we perform a partial pulpotomy to preserve the pulp vitality. And if there is pulp exposure with mature roots, then we perform endodontic treatment, and we can also use a fiber post as an aid in enhancing the retention of fractured segment. If at all, proper reapproximation of segments is possible. In certain cases, the complete coronal fragment might be unrestorable, and the remaining, the radicular segment of the tooth might be slightly below the level of the gingiva. So in those cases, orthodontic extrusion is recommended. The drawbacks of this procedure are that it is very slow and cumbersome, and secondly, it has to be done only when we are sure that the orthodontic extrusion will not compromise the crown root ratio. If all these indications are met, then the procedure can provide excellent results. There is also something like surgical extrusion of the apical fragment. It is indicated in cases where the root is long enough to accommodate a post-retained crown after surgical extrusion. So surgical extrusion is faster than orthodontic extrusion, and it is a safe and rapid method for management of such cases. One thing that needs to be kept in mind is that during surgical extrusion, the PDL should not be